Have you ever wondered why you never snored at 30? Why at 42 you might snore a little bit more? And why by 54 you're snoring so much that you're going to a dentist looking for a snoring appliance to help you sleep at night? My name is Dr. Seema Agarwal. Welcome to Your Mouth and More and my course on the introduction to the Menopause Airway. My goal is to help you understand the hormonal changes of menopause and how they affect your airway. As we enter menopause, many hormonal changes occur in our body. They have ramifications on the structures of the airway, including fat deposits at the base of the tongue and around the airway, which reduce airflow. This actually results in micro awakenings and little chokings at night. If you had little chokes all day long, you wouldn't accept it. You'd know that something was wrong. But because you're not necessarily aware of it at night, this constant stressor is on your body, and it has huge ramifications on your well-being. It affects heart disease, stroke, and neurodegenerative disease risk. It's a tremendous strain on your overall well-being, and you wake up with a headache, feeling foggy, and so much more. So take a look at this course. I'd love your feedback, and I'd love to hear more from you. There's a more comprehensive version with some extra videos on my website. The link is below. This is Your Mouth and More. The course was under my old name, Your Mouth Matters, but either way you say it, your mouth matters more than you think. I hope you'll enjoy the course. Take care.
So what exactly is sleep apnea? Well, if you look at the word itself of apnea, it comes from the root words of means no and pnea from air. So it's a state of no air while you're sleeping. Now, sleep apnea is a condition that makes you stop breathing while you're sleeping. There are actually two kinds of sleep apnea: obstructive sleep apnea, which we're going to be discussing today, and central sleep apnea, where it's a signaling issue between your brain and your body that it stops breathing. That is far beyond the scope of this discussion and something you should definitely discuss with your MD if you have any concerns. But what happens when you stop breathing? Well, normally when you stop breathing, you have no oxygen. One would think that you would die. But the body is very wise. The body actually has built-in survival reflexes. And what actually happens is, as you immediately stop breathing, you go into a survival wake-up, whether it be a micro or a full wake-up, and you gasp for air, like that. Your lungs immediately want to fill up with air. And that is what keeps you alive. The concern with obstructive sleep apnea is A, why is it happening? And secondly, how many times is it happening and how many awakenings are you having? Because it really interrupts your sleep cycle, and it's very detrimental if left untreated. So I'd like you to take a look at this video here, and it kind of is a visual of what's actually happening in obstructive sleep apnea. So if you take a look, the airflow is flowing through, and then it comes out. And here's a close-up here. So here's a close-up, and you take a look, and you'll watch that the air is going to flow in. There it is. And it goes into the lungs, and then the air flows out of the lungs, which is a beautiful thing. But then the tongue falls back, and all of a sudden, as you saw, the air was blocked. So the tongue is the obstruction in obstruction sleep apnea. Also, I'm going to point out this red flag right here. So this red flag you're going to see throughout the presentation are something to really pay attention to, and real key takeaways as far as what you're going to learn from here, as far as the root cause and some of the solutions pertaining to obstructive sleep apnea. So when we talk about apnea, we also have to discuss hypoxia. Hypoxia is a low oxygen state. So whether it be a no oxygen state or a low oxygen state, we consider these to be AHI events, apnea, hypoxia events, So the Apnea-Hypopnea Index is used in the medical community, and it is the number of times that you have a no oxygen or a low oxygen event, and the number of times per hour. So what I want you to consider and think about very seriously here is that under 5, so up to 4 interruptions per hour, and they can be micro awakenings. You may not even be aware of them. Up to 4 micro awakenings an hour is considered within normal. And that is a big concern, because when you hit to the 5 mark as an adult, then that means that you're actually having, now you're being diagnosed as having mild sleep apnea. Now, the concern is, what are the implications on the body of those 4 awakenings? Let's take a look at that. Now, the Apnea-Hypopnea Index, as we mentioned before, indicates whether you're in the normal range, a mild, a moderate with 16 to 29, or up more than 30 as severe sleep apnea. But think again what it means to have an interrupted sleep. For those of you who may be parents or may be mothers and remember having young children, you would have one wake up with the baby. You'd be so tired. Then you have two wake ups with the baby, and you'd be so tired. Three or four, whether or not you had to get out of bed, your sleep was interrupted. And you remember how that zombic state felt. And we just kind of went through the day, but you're really not functioning. So now you fast forward a few decades and your body has gone through menopause, and you sort of look at that and say, what is my four awakenings an hour doing to my body? Plus, now we're older. We have other wear and tear of our body. There may be some mild inflammation. What are the imposition of having even four wake ups an hour, assuming you're not in the apneic state? So I'd like you to take a look at this slide here regarding the six main symptoms of sleep apnea. This is what you would notice if you had sleep apnea. First thing you may notice is snoring that's maybe mentioned by a partner. And snoring is actually the sound the air makes as it goes through an airway with some impediments. So you can have a mild snoring, you could have a moderate, you could have that full out bear in the woods sleeping snoring. But those are the things that you may notice and something to definitely think about because there probably was a point in time in your life when you didn't snore. So the other thing you may notice is that breathing pauses while you're asleep. And a sleeping partner may notice this, and you're actually going to notice that your breathing actually stops. And you may wake up, as we say in number four here, you may wake up with a sense of choking. So those are your breathing patterns while you sleep definitely have to be considered. You might find yourself waking up repeatedly through the night. You might just find yourself waking up, you change your position, and then you go back to sleep. And those are all indications that something there was on some level, there was some disruption of your sleep. Unusual breathing patterns, whether it's very rapid breathing, any deviation from your normal ebb and flow of your breathing is some indication that you may have some form of sleep apnea. One of the other things you really maybe must be aware of is daytime sleepiness or drowsiness, especially in women. If you're not getting adequate sleep or restful sleep, you're not in the need of just a short nap. You need a nap, like a long nap. You just need to restore your body. And without, you really don't feel that you can function. So that's something you really need to be thinking about is your level of exhaustion. And are you waking up feeling refreshed or not? So the question now comes down to what changes in menopause? The hormonal changes of menopause are quite profound on a woman's body. But they also you have to consider that they increase the level of inflammation and fat deposits in the body, and that alters the airway size. Let's see how. I want to take a look for what this slide here, and this is an anatomy textbook that I used in school. And here we go. This is what a normal tongue should look like. Now, if you look at the normal tongue, there isn't any fat, aren't any fat deposits in the tongue. It's actually made of many muscles put together, of extrinsic and intrinsic. The tongue is actually quite a feat of nature itself, in that it has many nerves coming in, many muscle functions that it performs in the act of speaking, swallowing, tactile, taste, all those things. It's a very complex part of your body. But if you take a look here, now normally the tongue position rests at the roof of the palate, but when the tongue is at rest, the tongue shouldn't occupy the whole space. There should be room above the tongue, behind the tongue for food, water, air to be able to actively flow through without any impediments. So looking at this here, we want to consider a few things in a normal versus somebody with some sort of sleep apnea as far as their presentation. So if you take a look at this here, you'll see the green area here is the area of airflow, of open and free airflow. This is a normal tongue position, and you have normal nasal sinuses here. But as you develop fat deposits under the tongue, under the chin, in the airway portions, you'll notice the neck circumference is getting larger here, as well as there's now an impaired flow of air. If you look at the green space, it's much smaller here. And the other thing you have to consider also is a lot of the inflammation that comes with the fat deposits hits the nasal passages as well. So the nasal passages here are actually going to be quite normal and intact, and you'll be able to breathe freely through your nose. But very often, this individual will have a stuffy nose or have a hard time breathing through their nose, or they may actually have a fully blocked nose and then are shifting over to mouth breathing, which has a lot of detrimental implications on the mouth for the microbiome, for tongue position, the resting position of the tongue, the implications on the jaws. So you really have to be mindful of the fact that the inflammation that accompanies this fat deposits also causes a blockage of the nose and causing some sort of impairment in the airflow as well. Now, when we consider fat deposits in the airway, at this point in time, every individual is probably thinking, oh my gosh, I have sleep apnea, so how would I know? Well, first of all, go by your symptoms and speak to your MD. But when you go to the doctor, one of the things they're going to look at is in your mouth, they're going to look at the air passage space. So one thing they would consider is how open is the airway versus how closed is the airway? How narrow is the tongue versus how much larger is the tongue? Where is the epiglottis? How far does it come down? Are there any adenoids or tonsils involved? How much actual airspace is available for the air to flow through? And that's a medical assessment. And if you ever have gone or had seen someone go for surgery, that's one of the things that they always check for. Now, here we have a red flag because this is actually a very important thing and something you can do at home to check, and that is neck circumference. So, neck circumference is an important factor because we all, ethnicity and culturally and stature wise, we have our own base neck circumference. But if as we age, your neck circumference is getting larger, if you're noticing that your collars are not doing up as nicely or they're feeling a little bit tight, then something changed in the actual width of the neck. And so there are guidelines as far as neck circumference where we really get into an area of concern. And for women, that's 16 inches, and for men, that's 17 inches. Some studies say as much as 14 inches for women or 15 inches for men. But once you're hovering in that range, even just below the red flag zone, you really do have to be concerned and revisit your symptoms as far as is there an impediment of airflow as you sleep? Now, you can't discuss sleep apnea without considering some other possibilities as well. And the fact is, can you have sleep apnea and not be obese? Absolutely. Up to 50% of patients with sleep apnea are not obese. And therefore, we have to think about, first of all, they're definitely harder to diagnose. And second of all, the analysis of the symptoms is very critical. But those individuals we find may not necessarily have the fat around the waist or the neck, but they are prone to having fat deposits at the base of the tongue. So when you consider the mass of the tongue is somewhere between 100 and 150 grams, the actually to add 1 ounce of weight, say 30 grams, and if it deposits at the base of the tongue, you wouldn't notice that in a thin person on the scale. But that deposit of fat can alter the size and position of the tongue, in thereby actually altering the airflow. And therefore, that person has to really be considered to being treated for obstructive sleep apnea because of all of the implications. Now, this is one of my favorite slides, and it's taking a look at the muscle to fat ratio of someone who has sleep apnea. Now, in this case, they're actually looking at first, they're looking at menopausal women who are very similar in BMI, but one has sleep apnea and one doesn't. Can you guess which one? So in this instance here, this person has a fat volume, a tongue volume, sorry, and a fat volume that is much lower, and a fat percentage that's much lower than this individual. And you can see how much space the tongue takes, how much muscle, how much fat there is, the space that's occupied, the imposition it would have on the airway here. And you can understand that this is the person that would have sleep apnea. You can see the excess fat deposits under the chin here versus this individual that may not have sleep apnea, but is a very similar body composition or mass as we would compare. This slide here shows where the fat tends to deposit. So in a normal tongue here, if you were starting to have fat deposits, we'll notice that the fat doesn't begin at the front. So you look in your mouth, you're like, my tongue looks fine. The tip of my tongue looks fine. But the fat deposits begin at the base of the tongue and then accompanied with the airway as well. So that is where the tongue size and repositioning happens. And that's where we really want to be concerned about this. The other thing you really have to consider as far as a red flag is something called a scallop tongue. Now, a scallop tongue is when your tongue volume and mass increases so much that your archway and your teeth haven't changed, but you're getting an indentation on the teeth of an imprint of the teeth on the tongue. And that basically is an indication that that tongue has increased in size so much that now it's being pushed against the teeth and they're actually having an indentation of the teeth on there. And that is a real red flag to speak to your MD about and to speak to your dentist about, because now we're saying that there is really not very much room in that oral cavity for anything other than the tongue because it's taking up all that space. So, what are the risk factors of obstructive sleep apnea? So, we've discussed these two quite a bit, the obesity being the greatest risk factor in determining if you have obstructive sleep apnea, and the neck circumference is very critical. But other things you need to consider as well are whether or not you have a narrow airway from tonsils or adenoids. These may reduce the airway opening size and definitely need to be addressed. There are some indications for surgery. There are some indications where you may say incurring certain habits that would help reduce the adenoid and tonsil size, but you have to still acknowledge that their presence is actually reducing the amount of space air has to move. The other thing is use of sedatives or muscle relaxants. So these, if you take a muscle relaxant, you get into a deep, deep state of relaxation. The tongue falls back just as the muscle relaxes, and that might be why you're having some sleep apnea. And it may not be a fat composition issue. The other thing, as we mentioned, was nasal congestion or smoking, and that causes an inflammation. So we have hard tissues and soft tissues inside our body. So the inflammation that's caused by smoking, or if you have a lot of nasal congestion associated with it, causes a swelling of the soft tissues. Again, it's all about the space and whether there's a repositioning or a soft tissue taking up that space, the space becomes less and therefore airflow is impeded. The other thing is considering your medical history. There's a lot of conditions that are associated with sleep apnea, everything from PCOS, hormonal imbalances, diabetes, thyroid issues, high blood pressure, congestive heart failure, asthma, and GERD is actually gastroesophageal reflux, is actually a complex condition that involves both the stomach and the gastric system as well as the airway. And it's also an airway protective response. So those things are all things to consider as far as contributing factors and risk factors. Now, what are your health implications if you do have obstructive sleep apnea? Well, as we mentioned, it's a low oxygen or a no oxygen event numerous times that you may not be aware of through the night. So that impediment of oxygen has tremendous strain on the body, which presents itself as heart disease, stroke, obesity. It's a loop almost, because obesity can cause sleep apnea, and sleep apnea causes so much inflammation that it makes it hard for your body to balance itself, that it results in obesity. So it's really one that you have to pay a special attention to. The other outcomes are possible are Alzheimer's, neurodegenerative diseases, dementia, inflammation all over the body, type 2 diabetes with impaired insulin management, glucose management. And the other one is car accidents. The sheer fatigue of it all can make you sleepy on the road and result in a devastating outcome for anyone involved. Now, the four main changes we really have to consider in the menopausal airway are: the beginning, we have the estrogen loss that leads to visceral fat gain. So that leads to fat deposits as in the abdomen and in the neck and surrounding tissues. That in itself is associated now with fat deposits in the tongue, although those can't happen independently, but this results in reducing the open space of the airway. That outcome then is that the larger tongue combined with the smaller airway is what produces the apneic or hypoxic events. So, what are the potential changes to the menopausal body? Like, how does this affect each one of us? So, one thing we have to consider is at the beginning of the menopausal process is that estrogen declines. So, whether or not you're on a hormonal balancing protocol, whether or not you are taking a hormone replacement therapy, that is not the discussion that we're having here. We're saying that a normal flow is that in menopause, there is a decline of estrogen. And I like to discuss what comes after. But we're going to go backwards about it because we know that the outcome very much has to do with neck circumference. But how do we get from estrogen decline to neck circumference? And where is the key part here? Well, we know that neck circumference increases from inflammation and visceral fat deposits. We know that visceral fat follows when we have an increase of body fat, right? And we know that body fat percentage increase becomes because of insulin resistance. And insulin resistance comes because of impaired glucose management. So this here, I should have put a red flag here, I apologize. Impaired glucose management actually is the element of control. This is the concrete domino that is going to go and fall all of the other dominoes once you have estrogen decline. So your glucose management is not just not eating candy, but it's your overall blood sugar management for your body. And it really behooves us as we enter menopause to really have a knowledge and control over that and have an understanding of, what are my blood sugar levels? Am I in control? Am I a pre-diabetic? Am I hovering? Is something changing? Because the implications of this is what follows, and that can be devastating. So, how can a menopausal woman, as myself, reduce a risk of obstructive sleep apnea? Well, this is the holy trinity that I say. One is to reduce inflammation, to reduce body fat percentage, and reduce neck and tongue fat. Now, the implications of these are all here, but I want you to just pay a little attention to reducing inflammation, because inflammation is also accompanies with a lot of fluid retention. So as we get a little bit puffier, what happens is that fluid also in your and along with your entire body around surrounds the chest cavity. And so, in the upper part of of the torso, there's some fluid accumulation. And one of the things we find the benefits of exercise is that as the movement of those muscles, and first you may feel some like, oh, it's hard to exercise, and obviously you should definitely have a clearance from your MD to make sure you are cleared for exercise. But even as you're walking or something or not, you may find some resistance. And what we'll find is that the actual active movement moves the fluid and disperses the fluid, and over time reduces the fluid, which makes your lung function and thoracic function and airway function a little bit easier. So that's one of the magical benefits of exercise and how it benefits reducing inflammation. So we can't have a discussion about the airway and not talk about nasal breathing, even as a dentist. One thing you have to understand is that the body itself, the primary source of breathing or primary pathway is actually through the nose. The mouth is the backup system. But just like anything in life, you can't live off of your backup system. You can't run your computer off the backup system. You can't run your finances, your car. You have to have the primary system working. Similarly, in the airway, we really want you to be able to comfortably breathe through your nose so that your lips can close at rest and the tongue position is kind of in a proper alignment, and you can breathe through your nose. But what keeps you from breathing through your nose? Very often, that's inflammation. You may have a deviated septum. You may have some other concerns that do need to be addressed. But free nasal breathing, which now allows lip closure at rest, is actually a condition in which you have optimal breathing and airflow. It's also been associated with nitric oxide increases. But aside from that, it's about the airflow and the tongue position that I really do want you to give due importance to the fact that a free open airflow through the nose is absolutely critical. So if you've gotten anything out of this lecture and you feel that there's more to learn, then this is where you can find me and follow me. What's coming up next will be on YouTube, Facebook, and LinkedIn. Things to look forward to. And in the meantime, on Instagram, I'm at your.mouthmatters. And just be a lot of information based on functional medicine and root causes associated with the mouth. And right now we're focusing on the menopause mouth, but there's lots to talk about. So we will definitely be broadening our horizons in the future. So going back to treatment options, I just wanted to recommend here, first of all, see your MD for a proper diagnosis. If you think you have sleep apnea, your MD is the person who will give you a proper, concrete evaluation and assessment of that. They may refer you for clinic and or combination home-based sleep studies. When you get your report, look at your report. Find out how many awakenings, your AHI index, you're having per hour. Where do you really fall in that? And now you have to think about what are the implications of each of those numbers. You can see your dentist for a sleep appliance if needed. Do anything you have to do to get your airway patent and open. But understand that the temporary repositioning of the jaw is not a permanent root cause solution as to why there was impaired airflow in the first place. If you have enlarged tonsils or adenoids, if you have fat deposits around the tongue, if you have fat deposits around the neck, those things will not be solved by the wearing of a dental appliance. The dental appliance will encourage airflow while you are accompanying that with root cause solutions. The other thing is we mentioned the respiratory system health. From nose to the bottom of the diaphragm, work on your respiratory system. Encourage movement of air, encourage the functioning of your lungs, and get those muscles in order so that the airflow happens easily and freely. Exercise, as we mentioned, but also reduces fluid accumulation, and including increases respiratory muscle tone, and that's an important thing. The other thing to think about is also myofunctional therapy. You can see a myofunctional therapist. There's some amazing myofunctional therapists out there, and they're much easier to find now online. The other thing is you can look for myofunctional therapy videos if you like, and that is something that you can do at home and as far as exercises for the tongue. And the last thing is actually singing. Now, please understand, as a dentist, I'm not saying that singing is going to cure your sleep apnea. It's not. It is not a root cause solution. But as speech pathologists use it for the purpose of toning and use of the muscles in the airway, it is something you can do. And I find it quite enjoyable. So I encourage you to sing in the shower. And that's where I was discussing at the beginning. Here are some tools. Now, I'd like you to think about one thing. If you're checking your body fat composition, like an in body device or something, understand that that's a body fat percentage and not your tongue fat percentage. And so please don't look at whatever that number is and say, well, this is my tongue fat percentage. We haven't scientifically directly correlated the number exactly. So don't be dependent, don't rely on that itself. SnoreLab is one site or app you can use that records you at home, but I would do this as an adjunct after you've spoken to your MD and just for your own self awareness. Some people use wearable devices like an Oura Ring or an Apple. I have no affiliation with any of these things I'm discussing today, but these things you may find helpful as an adjunct to just sort of say that I'm getting more data on reliable data on what my sleep state is and what's happening to me while I sleep. Singing, as we mentioned, used by speech pathologists. These are some myofunctional therapy videos I found. There are many, many other good ones, and you can take a look at those. Here are some of the resources that I've used today, and I hope that that was fine. You found that helpful. I encourage you to read and to look into as many things as you can, and be an advocate for your own health and for your own airway because it's really a critical part. When we do emergency medicine or CPR, the first thing in the ABCs is the airway, and without it, nothing else really functions. So do pay attention and love your airway. So that concludes our discussion today. As I mentioned, my name is Dr. Seema Agarwal. You can find me at your.mouth matters. I always say there's lots to talk about, lots to smile about, because I truly believe and know that your mouth really matters. Thank you and take care.